Thank you very much, team, and thank you very much to our participants today. Good afternoon and welcome. Thank you so much for taking the time to be here today. I know it's a very busy time. Our session today is called Caring for Long-Term Care Residents, a message of hope from our government. You'll be hearing from some of our special guests very shortly, but before we dive in, you'll notice that all phone and audio lines have been muted in an effort to eliminate background noise and distractions. We have protected some time for a question and answer period, so the session will be very interactive. That will be at the end of today's webinar, at which time we'll invite you to type your questions into the chat box, and one of our session organizers will do our best to relay these questions on your behalf. Our session today is being recorded and will be made available to all participants following the session. The webinar will also be archived on the OARC website. So at this time, I'd like to invite OARC Executive Director, Dee Lender, to formally begin our session today. Thank you, Dee.
Thank you very much, Melissa. Welcome, everyone. We are so pleased to welcome many residents and team members of long-term care homes and their valued supporters today. We are thrilled to welcome a wonderful panel of speakers from government to offer their messages of hope and to answer some of your questions. Unfortunately, Premier Ford was unable to be with us today due to some prior commitments. However, he did send us an email letter yesterday, and I do want to read a couple of excerpts from his letter to us that, again, he sent through yesterday. And I quote, "The situation in our long-term care homes is serious, and I appreciate your insight on the direct experiences of our vulnerable residents. I want to commend you for your leadership on their behalf. It is needed now more than ever. Courage can only begin to describe what the last few months have demanded of us. As we all know, long-term care homes have been the front line of COVID-19. Not only here in Ontario, but all over the world. The tragedy our province has experienced is immense, and I know many of you have felt it intimately with your own neighbors and families. While the majority of our homes have been able to manage, some have needed significant support. My thanks go out to the brave frontline staff who are sticking this through with us, and to the hospital and home care staff who have stepped up to assist. We are also indebted to the Canadian Armed Forces for lending their expertise to some of our hardest hit homes and working to protect residents and staff. We are working every day to address the challenges posed by this virus and have much to consider to shore up the cracks in the long-term care system. As Dr. Merrilee Fullerton, Minister of Long-Term Care, has shared on a number of occasions, ward rooms, congestion, and staffing shortages have amplified the crisis of COVID-19 in our long-term care homes. Her team has been working hard to create a roadmap to bring our capacity and staffing supply into the 21st century. Trust me when I say that no one is more committed to making real change for our province's most vulnerable than me and my caucus. With Minister Fullerton at the helm of long-term care and Christine Elliot as Minister of Health, I know you are in good hands as we continue to fight this virus. I understand that in these difficult times, not being able to see your family members and loved ones has caused a strain on all of you. As Ontario looks toward a gradual reopening of the province, our government has announced the welcome news that visits will resume in a safe, staged-in way. I hope that your reunions with loved ones are a bright spot in this otherwise trying time. Thank you once again for your invitation, for all you are doing on behalf of our residents. They are the seniors who built this province, and I am heartened to have your support in providing them with the care and support they deserve. So that again is a letter that was sent to OARC yesterday by email. We are pleased that Premier Ford is dedicated to the residents of long-term care homes in Ontario and are encouraged by his willingness to work with OARC and the residents of Ontario. We look forward to being a vital addition to the decision tables and upcoming commission. Thank you, Premier Ford. At this time, I am happy to introduce our next speakers, the Honourable Christine Elliot, Deputy Premier of Ontario and Minister of Health, and the Honourable Dr. Merrilee Fullerton, Minister of Long-Term Care. And I just have a brief introduction for both of our guests. The Honourable Christine Elliot. Minister Elliot graduated from the University of Western Ontario with a Bachelor of Law degree. She then built a successful career in business and law, working first as an auditor at one of Canada's largest banks. Minister Fullerton later co-founded a law firm with her late husband, Jim Flaherty, where she specialized in real estate, corporate law, and estate law. Her pro bono legal work for charitable organizations gained her the recognition as a Rotary International Paul Harris Fellow, the highest award with Rotary. As well, Christine is a co-founder with the Ability Center in Whitby, a facility built with the vision of celebrating all people, regardless of ability. The center has become a hub of its community, hosting various Parapan Am Games events in 2015. In 2016, Christine became Ontario's patient ombudsman. She currently serves as the Deputy Premier of Ontario, Minister of Health, and is the MPP for Newmarket, Aurora. The Honourable Dr. Merrilee Fullerton. Having graduated University of Ottawa Medical School, Minister Fullerton practiced locally, first serving out of the Carleton Place Hospital and then as a family physician at the Med Team Clinic in Canada. Dr. Fullerton has been very active in professional medical associations and local healthcare organizations, including advisory roles with both the Ontario Medical Association and Canadian Medical Association. And she has membership in the City of Ottawa Board of Health and the local LIN, Local Health Integrated Network, serving Ottawa and area. She's a constant advocate for better universal healthcare services, particularly long-term care services. In June 2019, she was asked by Ontario Premier Doug Ford to serve as Minister for Long-Term Care. Her ministerial responsibilities also include a seat at the Treasury Board Committee of Cabinet, and she is the MPP for the riding of Canada Carleton. With that brief introduction, I would like to welcome both ministers. Both ministers are going to share a respective message to us, and then we have a few questions for them. Minister Elliot, would you like to begin, please?
Yes, thank you very much, Dee, and good afternoon, everyone. I really appreciate the invitation to join your annual general meeting and to speak to you today. I know the global outbreak of COVID-19 has been stressful on all of us, especially when we haven't been able to be close with our loved ones. This truly is an unprecedented time, but there is light at the end of the tunnel, and we can now see it. Every day, most public health units have been reporting fewer than 5 new cases of COVID-19, with many of them reporting no new cases at all. Ontario's testing is at historic levels, with the province now having processed over 1 million tests. As a result, our rate of new COVID-19 infections remains at all-time lows. Because of our collective efforts to defeat COVID-19, we have been able to open up more of our province. And of course, that includes family and friends being allowed to visit their loved ones in long-term care homes again. Something that I know many of you have all been waiting for many months. Since the start of this outbreak, our government has made the health and well-being of Ontarians, especially our seniors and our most vulnerable citizens, our foremost priority. we recognize that you are among the most at risk during this outbreak. And we owe it to you and to your loved ones to do everything we could to protect your health and well-being. Our government has taken a number of steps to support seniors and long-term care residents through these challenging times, including expanding proactive testing to quickly detect outbreaks, actively monitor the spread of COVID-19 in homes, and securing and delivering personal protective equipment to protect both frontline staff and residents. These efforts were guided by our COVID-19 Action Plan, long-term care homes, which Minister Fullerton will speak more about shortly. We will continue to do everything in our power to help and protect our long-term care residents. Our government has always been one that prides itself on really listening. And I want to thank you for sharing your concerns and experiences with us. Your feedback and input help guide our decision-making process, and we are always open to new ideas about how we can improve the services you receive so that we can support you. We are all in this together, and we are all getting through it together. We still have a lot to do, but together we are moving towards better days ahead. Thank you once again for inviting me to join you with, and I look forward to our discussion.
Thank you very much. I would like to turn the floor, please, over to the Honourable Merrilee Fullerton.
Thank you so much. Let me know if my voice is getting a little muffled. Sometimes I don't speak up as loudly as I need to, so please indicate if I need to speak louder. And I really appreciate the invitation to speak with you today. Very kind. And I would love to speak from the heart. I do have written remarks to get to, but I want to speak to you from the heart and tell you how much I appreciate what you do, how important what you're doing is for not only making a difference in your own way, but for all the other people that you can be a voice for. And I spent many years as a family doctor, and I always said, people need to be heard, they need to matter, and they need to be needed. And every life matters. And so what you do is incredibly important. And I just want to acknowledge the tragedy that has unfolded all over the world for our particularly for our seniors, our elderly, and those over 80. It really has been tragic. And Ontario is not alone in this. It's North America and around the world. And I want you to know that we are making progress in this. As much as we've been through COVID war, we are making progress, and we are returning our homes to a healthy and safe state. And that means safe places for our residents and staff, because you know that in order to provide good care, good quality care to residents, our staff need to be supported in this process, and they need to be supported. So, we acknowledge the tragedy, and I want to also make sure that you understand how important it is for us to listen. I was a frontline family physician for almost 3 decades, and I used to get very frustrated when I felt as a frontline provider, someone who was, with patients regularly, that sometimes the government didn't listen. And I vowed to listen as a politician, and our government listens. I can guarantee you that. We have many things going on, and sometimes we have to listen very, very carefully. But we must do that, and we are doing that. And ultimately, we need to find solutions. We have to find a way to make things better. And you heard Minister Elliot talk about, we are in this together, and we all have a role to play. And I said in the chamber when I stood the day after the pandemic was declared globally, I said, this is a time for caring and compassion. And it truly is. It's been a challenging time. And I know it's touched many of you personally. And I, too, have gone through family members in long-term care. So some many years ago, some just a few years ago. And so I know how incredibly important it is that we continue to move forward and hear your voices and make positive change. We have so much work to do, and our ministry was formed really only a few months before COVID-19 hit hard. And we had already started to embark on understanding why there was a staffing crisis in long-term care. And we have an expert panel that is due to report on that in July, so that is coming. But that work is tremendously important. And we have to peel back the layers and understand what it is, because we can say we need adequate staffing. But what does that mean, and how do we get there? Because we have to understand the nature of the work that our frontline staff do, where the obstacles are, how we can support them, and how we retain them. These are so incredibly important to our residents and staff to work together. So the encouraging signs that we're seeing are helpful. And so, as Minister Elliot has said, there are brighter days ahead. And we are seeing that now. And what many people don't know is that the majority of our homes were never in outbreak. 70 to 80% of our homes were never in outbreak. And in many of our homes that were in outbreak, it was often one resident or one staff. And in some cases, there were dozens of homes where there wasn't a single resident with COVID, but the staff were isolating at home. And we did that because we wanted to make sure that public health could get in early. So that's why we made an outbreak, one resident or one staff, even if the staff was isolating at home. And other homes were terribly, terribly affected in a most heartbreaking way. And we've all heard those stories. But things are improving. We integrated with the hospitals. We allowed their expertise with infection prevention and control measures to come in. And we allowed the staff from the hospitals to assist our homes and do improve training on PPE. And I'm sure everyone knows what PPE now is. A few months ago, nobody knew what that was, personal protective equipment. And now our homes are coming out of this. The homes that were affected are improving. And so we, as of yesterday, there were 242 outbreaks in long-term care that have been resolved. And 67 of the 626 homes in Ontario were in outbreak yesterday. And we're kind of hovering at that 67, 64 number, because every now and then with the additional testing that we're doing, we're finding a staff member that's testing positive or a resident. And even if a resident doesn't get tested, if they have sniffles or they're having symptoms, we assume it's COVID-19 until proven otherwise. And so even that is called an outbreak. And the good news is that our green homes, who are the low-risk homes, you've probably heard our tiering of it, red, yellow, and green. We've moved from 450 homes in green to 591 homes. That's about 94% of all long-term care homes that are in the green. And so we're hopeful about that too. And our number of high-risk red homes, which you've all heard about in the media, no doubt, and the ones that needed the most support, have gone down from 36 to 9, and that's a reduction of 75%. But this is COVID-19 is a brand new virus to the world. It's spread rapidly, and we were trying to learn with our medical experts and our scientific experts, such as the Chief Medical Officer of Health, about the evidence. And so when evidence is still forming, that can be a challenge. But we knew from the very beginning testing was absolutely critical, and kudos to Minister Elliot for getting that up and going. And we've expanded that to record numbers of tests. So that's very hopeful. And the PPE supply, no home has been left without PPE, even though it might have been coming at the last minute in 24 hours or 48 hours. That was because, as you've heard, it was sort of the wild, wild west of PPE, and you've heard the federal minister, Chrystia Freeland, say that because some of our shipments were never arriving. And so it was a very unsettled time. But we were basically metering out small amounts of PPEs to make sure that there was no home left without. And to my knowledge, there was no home left without PPE, even though it would have come, you know, within 24 hours. There was some narrative that the homes were not receiving that, but we have done with our regional tables and the command table everything possible to make sure that came in perhaps in the short time, but a necessary time. And our government has put dollars behind our long-term care strategies as well. You know, $1.75 billion for new capacity. We knew that the old buildings were an issue, the ward rooms, and yet our long-term care homes are the heart of our community, and they're homes where people rally behind, and you've seen that in many of our homes that have been hard hit, and some that haven't. The community and the community members really do support their homes. So there are many, many lessons that we've learned during this, and taking the advice of our medical experts while evidence is still forming is a challenge, but we've been keeping up. And our rigorous inspections. Every home has been inspected. Our inspectors have been available on the ground and in contact with our homes. And I think that's just incredibly important because I know that there's been much said in the media about that. And our inspectors have been in constant touch with our homes. So I want to make sure that you have an opportunity to ask questions. And my heart goes out to each and every one of you and your families. It has been a really difficult time for many, and it's unprecedented. And I'm grateful for your insight. And we must keep these lines of communication open and do whatever we can to support each other in this. And my mission is to support you. So thank you again for your kind invitation, and I look forward to your questions. Thank you.
Thank you very much. It's Steve speaking once again. Thank you very much, ministers. Melissa, while you are getting Sharon poised with her webcam, I just wanted to draw attention to the button that both you ministers are seen on the screen wearing. These are OARC buttons. They say "Ask a Resident," and I just wanted to declare what that means. People wear these buttons as a declaration that the resident voice matters, that all decisions made in the operations of a long-term care home must revolve around resident opinion, resident choice, preference, and involvement in the process of decision-making. It's a reminder to administrators, team members, managers, everyone in the home that this is home to each resident. And as such, being consulted and included in decisions is absolutely of paramount importance. So it's heartening and lovely to see both ministers wear these buttons. So thank you for doing that. I'd like to introduce you now, please, to Sharon Cook. Sharon is the president of OARC. She is a resident at York Region Newmarket Health Centre Long-Term Care, where she's lived for 11 years. For 7 years, she has been the president of OARC, and she's been part of her residence council leadership team in her own home for many, many years. She has over 35 years of experience in her work life, in office administration and management, and she has also experienced the profound challenges associated with balancing work and home life, caring for palliative family members over the years. Sharon has a great passion advocating for a better quality of life for all persons. And Sharon, as president of OARC, I would welcome you now to please ask a question to both ministers, after which both ministers will answer from their respective positions. Thanks, Sharon.
Thank you. Good afternoon, Minister Elliot and Honourable Minister Fullerton. A long-standing concern is that the voice of long-term care home residents is typically not present at decision-making tables. We believe government's commitment is to resident-centered focus, as articulated and the long-term care legislation. It is imperative that residents directly impact decisions that affect the long-term care system, our homes. Our question is this: please explain how the resident voice will be infused into the development and implementation of the roadmap to fix the system, so that long-term care homes are places of excellence where residents thrive. Thank you.
Minister Fullerton, I wonder if you could start, please.
I'd be happy to. I just want to make sure that Minister Elliot, if she has to leave, I don't want to delay her. If she needs to go first, she's absolutely welcome to do that. Minister Elliot, what works for you?
No, Minister Fullerton, please go ahead.
Okay, perfect. Thank you so much. Thank you so much. So I couldn't agree more, Sharon, how incredibly important it is. And I just want to indicate the state of emergency that Ontario has been in for the last number of months, and what an unusual, unprecedented, difficult situation that has been for people in long-term care, residents, staff, and families. And that, having said that, at other times, the decisions absolutely have to be resident-focused, and also during the state of emergency, but understanding certain measures get taken on an urgent basis because of the need to act quickly, and that unfortunately has happened and has made it hard for people, such as our essential visitors only. And so I want to acknowledge that. Looking at the Residents' Bill of Rights in long-term care, that is an absolutely critical piece, and residents' rights must be fully respected and promoted. So that's, first of all, a mechanism that we can continue to support, and that respect and dignity for our residents must be held at the center. And we were in the process, as I said, in the first few months of our ministry existence, in creating a resident-centered system. And Sharon, you mentioned the concept of home, and I have spoken to the ethics table about our issues during the pandemic. And really that concept of our long-term care homes being truly home. That is where people live. It's not where they stay, it's where they live. And so we have to understand that individuals, whether it's the individual or the family member that may have power of attorney or be the guardian, people have to be included in the decision making. And it's about the safe environment and a dignified environment. And we have to change and evolve. I started my career in long-term care back in the 1980s, and there's been some progress made. But clearly, we need to redesign long-term care. And it needs to be a way that is integrated into the community so that people want to go visit. Integrated into the community so we can get expertise. And that residents' voices can be heard. So the family council, the association of residents, it's absolutely critical that we have the pipeline to that communication. And unfortunately, I think what happens is in a state of emergency or when homes are in severe outbreaks, the first thing that falls apart is communication. And it should be the last thing that falls apart because it's needed even more during that time. So we have to look at how that communication is achieved in an emergency, in a case where we might see a second wave. You've probably heard of that, and we're preparing for that. And so the residents' councils are absolutely critical, and also critical to identifying issues within the home. So maybe your own needs, the needs of the residents, but also you are eyes and ears within the home. And that's incredibly important to other residents as well. So we have we also had a stakeholder listening day, and I believe both the Ontario Association of Residents Councils and Family Councils of Ontario made presentations, and I appreciated your time with the ministry and the advisory group. And for the staffing study, Grace Welch, who is chair of the Champlain Region Family Council Network Advocacy Committee. She's a real champion and a past member of the Long-Term Care Homes First Family Council. and now the chair of the Champlain Region Family Council Network Advocacy Committee. And so I think she's really a champion. And there are other people like that too that we really need to bring people who are networked and interested in amplifying your voices. So the commission is another way. So we are launching an independent, public, nonpartisan commission that will be started in July to determine the impact of COVID-19 on long-term care homes. And some of it's pretty evident. I gotta tell you, you would probably agree with me. And other parts may not be as clear. So we have to understand the challenges in long-term care homes, and not only what they face in this pandemic, but also as we look forward to integrating long-term care into the broader healthcare system, to the expertise, to our communities. We need long-term care homes that are vibrant parts of the community and that connect people with people and support people. So I will end there. If Mr. Elliot would like to add on, that would be great. Thank you.
Thank you.
Thank you, Minister Fullerton, and thank you very much, Sharon, for your question. It is vitally important. And I can advise you that during my time as patient ombudsman of Ontario, I learned a lot. I learned about how the fact that our system, our health system and our long-term care system isn't centered around the patient or the resident. And that is what I bring to my role as Minister of Health, that we need to listen to the people who are receiving the care or living long-term care homes. You, as Minister Fullerton said, you are the eyes and ears. And you're living through it. You know what works. You know what doesn't work. And your advice and counsel is absolutely important as we try to build both a long-term care system as well as a healthcare system that is centered around the patient, or in your case, the resident. I think it would be shocking to many people because they feel that of course your system would be centered around the people that are residents or patients, but it's not actually. And that's been part of the transformation that we've been trying to bring about with redesigning our healthcare system before COVID-19 took over everything else. But we are going to get back to that, and listening to your voices is absolutely important. It needs to continue because if you don't involve the people that are living with the situation, then you're not going to end up with a very good product. So one of the things that we've done in the Ministry of Health was there was an interim, temporary patient and family advisory council. I have made that a permanent part of the ministry to have people who have direct experience to advise me on our healthcare system. And I know Minister Fullerton is dedicated to doing that in long-term care, and we're working together to make sure that long-term care continues to be an important part of the system, and it's connected and integrated with other parts of our healthcare system, because we know that it's sort of been seen as a standalone for far too long. It needs to be integrated because it's one person who goes through their healthcare journey. It may be in hospital, it may be from home, it may be in long-term care, but you need to have your healthcare system with you and follow you at all times. And that is what both Minister Fullerton and I are dedicated to improving.
Thank you.
Thank you, Minister. Thank you very much for your comments. I know that our time is tight, particularly with our technical issues at the beginning, but we do have a few more minutes with both ministers before we switch into the second half of our webinar, which is a question and answer and information time with Assistant Deputy Ministers Brian Pollard and Janet Hope. So in the last few minutes, I do have a few questions here for you, ministers. The first one, both of you spoke quite strongly about communication. And in directive number 3, the directive to homes within that document is that homes need to communicate the COVID-19 situation to residents, to staff, and to family members. And we at OARC hear on an ongoing basis that residents are often not receiving information about the status of the virus in their home and what the home is doing to keep them safe. So I'm wondering if you could offer any comments or encouragement to the homes in this regard so that residents receive information in a proactive fashion and so that they're not left feeling like they're in the dark. Minister Elliot, would you have any comments for that?
Yes, thank you very much. I think it is absolutely vital that the homes give information to residents on both COVID-19 and any other issues that may affect their health, as well as what they intend to do about it. Most homes have done well, but there have been some that have not done well at all, which is why the independent commission is going to be established, and we'll be asking those questions. People deserve to know what's happening in their home, and they need to be able to, they need to be provided with that information as well as their family members. And because this didn't happen as well as it should have across all of the homes, that's what we need to look into, because absolutely that communication is vital and everyone should have access to that important information.
Thank you very much. Our next question is on behalf of Lloyd Foster, who is a director on the board of directors with OARC. Melissa on our team is going to read the question on his behalf. He is a resident living at St. Patrick's Home in Ottawa. Melissa?
Thank you, Dee. The question is, what are the immediate and long-term plans for comprehensive testing for both residents and team members?
I'm not sure. And team members. So the immediate plans and the long-term plans to ensure that we have accurate surveillance testing.
To test residents, but I'm sorry, I still couldn't get the last. Residents and who else?
Residents and staff.
Staff. Okay, sorry, I think my line is just cutting in and out there. Okay, that's good. Thank you. It's Merrilee here. So I've got to tell you first of all, St. Pat's Home, is it the Ottawa St. Pat's Home?
Yes.
Yes. Oh, that's great. Near and dear to my heart. I followed that redevelopment for many years. So I'm glad to hear from you. So in terms of testing, absolutely critical piece to have this, not only the surveillance to understand what we call the asymptomatic spread or potentially pre-symptomatic cases, so cases where people might not have symptoms yet. And I would also say, as we open up to volunteers and visitors in a staged way, that is also important to understand how incredibly important that testing is. So the first round of testing was already completed a number of weeks ago. We're now into our second round of testing. And we will be going forward with a requirement for testing every 2 weeks of staff who are coming in and out of the home. So not only the testing that identifies whether COVID-19 is being carried into the home, but also looking at whether there may be family members or volunteers or residents that might not be symptomatic and also bring the virus. So we know that people over 80 often do not have the same kind of symptoms or any at all. They might just simply not feel like eating. They might just confused. And so this is something that our medical experts are learning about this virus. So we have to be vigilant. And right now, the test that we have is a test for COVID-19. I understand that federally, there is a test coming that will test for what we call serology to see if people are immune. But the federal government is starting those studies. But that is not available to us at this point. But obviously, long term, it would be helpful to know who is immune. And also the science is evolving on COVID-19 and how long that immunity might last. There's quite a lot of science and evidence that will inform the testing strategy. And something that is different about COVID-19 compared to influenza, for instance, is that this pre-symptomatic phase or asymptomatic aspect of it initially was not fully understood around the world. But as the weeks go by, there is more scientific evidence about that. So immediately, finishing off the second round, long term, we will be looking at that phased approach for visitors and opening up, and all the while being vigilant with the testing, also isolating anyone who is symptomatic. Even if a COVID-19 test is done, if a person has symptoms, they still have to be assumed to be carrying the virus and be in isolation. So there are many ways. The testing is not perfect, and we have to rely on as well. It's a combination effort and the expertise of our command table and Chief Medical Officer of Health and Public Health.
Thank you, Minister Fullerton. Related to the testing issue, are there any plans to introduce tests that are less invasive? We have heard that team members, staff members, and residents find the testing up through the nasal cavity quite painful at times, and in some cases are refusing to have the test because of the discomfort associated with the test.
I'll comment briefly, and then I'll invite Minister Elliot, because she certainly has the testing aspect to the Ministry of Health down pat. In terms of the discomfort, there is some evidence that shows potentially a pharyngeal swab from the throat might be as effective, but again, we have to rely on the Chief Medical Officer of Health and Public Health to inform that aspect of it. And certainly there are rapid tests that might be available, and we're hoping that those will be available, because certainly that will help. There was a bit of a setback with one of the companies, but my understanding is that is an easier test and does not require the nasopharyngeal swab. But again, I'm going to let Minister Elliot comment in a more fulsome way.
Well, thank you very much. And I actually have had the swab myself. I have been tested, and it's a little bit uncomfortable, but it's not terrible. And that said, we're constantly looking at new technologies. There was one that came forward that had been approved initially by Health Canada, but has had to be returned back for further testing because the swab that they were using wasn't completely effective, and there were some accuracy tests. So we're always looking for new ways to test, and we'll continue to do that. We're also looking at an exposure notification app, which we just announced today, that some people can use. It's an app you can download within the next few weeks. That if you do download it and you're in contact with someone else who's downloaded it, it's privately protected, but it will tell you that you've been in touch with someone with COVID-19, which can then get people to go for testing where they might not have otherwise. So that is something that perhaps might be used by staff in the future to know if they have been in contact with someone, and that they can go and be tested on a more proactive basis.
Thank you. Thank you. So we just have a moment left. I'm going to try to squeeze in one more question. Residents have been isolated, as we know, from friends, from family, from their co-residents in their homes for weeks, over 3 months, in fact. We understand the tremendous adverse impact that this isolation has on residents and their families. How is government supporting residents with their psychosocial and emotional well-being? Minister Elliot, can you comment?
Elliot, if I could just speak for a moment to that. We know that COVID-19 has been very, very difficult for everyone, especially for people in long-term care homes who've not been able to see their family members for several months. This is, I'm sure, incredibly difficult to deal with. It's also been something that's been very difficult for a lot of people who've just they stayed in their homes, as they were asked to do, for several months, and they may have some additional financial stress as well. Some people may have lost their jobs. All that to say that we know that there's going to be many more mental health challenges for a lot of people as we exit the peak of the COVID pandemic. And we actually introduced our long-term mental health and addictions plan, Roadmap to Wellness, just before COVID-19 struck us, which we are now bringing forward once again. We did invest $12 million into some online resources during the peak of the pandemic, but we're also going to come back to make sure that we can help people that are experiencing anxiety or depression, particularly within long-term care homes. So we want to make sure that everybody who needs that kind of assistance will receive that assistance, because mental health is equally as important as physical health, and we want to make sure that everyone is able to come out of this with all of their both physical and mental health needs being met.
Thank you. Thank you. It's Dee speaking again. I do understand, ministers, that you do need to leave. Minister Fullerton, your experience and history as a physician in our community speaks to your desire and commitment to doing no harm and to providing clear and equitable access to excellent medical care. Minister Elliot, your experience in law, community politics, and as the patient ombudsman speaks to your desire and commitment to the resolution of conflict and the provision of just and human rights-based decisions. So I want to thank you very, very directly from OARC for your time, your attention, and your intention to do whatever it takes to ensure that residents now and residents in the future are proud to call their long-term care homes home, a place where care and environment is excellent and where self-determination, choice, and empowerment is optimal. Ministers, thank you once again. I look forward to continued discussions with you in the near future. And with that, we'll say goodbye for now.
Very well
Thank you so much
said.
for allowing us to join you.
Thank you so much.
Thank
Take
you.
care, everyone. Thank you.
Bye-bye. So everyone, hang tight. We are now in our time of our webinar today to meet two Assistant Deputy Ministers in the Ministry of Long-Term Care. Janet Hope is the ADM for Long-Term Care Policy, and Brian Pollard is ADM for Long-Term Care Operations. Both Janet and Brian will be our guests until the conclusion of our time together today. First, with and from them, we will learn their respective responsibilities in the Ministry of Long-Term Care, and then we will shift quickly into a question and answer exchange with them. OARC extends a warm welcome to Janet and Brian now. So over to you.
Hi, are you able to hear me okay?
Yes, we can. Thank you, Janet.
Excellent. Okay, thank you. I think my slide is up, so I guess that means I'll start first and then turn things over to Brian. So hello, everyone, and thank you so much for inviting us to be part of this virtual gathering. Delighted to be with you. Let me just tell you briefly a little bit about my context here. I am very new to the long-term care sector. I am a long-time Ontario public servant, over 30 years, in working in a variety of different ministries and a variety of different portfolios. And last year, as you know, the government made the decision to create a separate Ministry of Long-Term Care. And as part of that, a decision to create a policy division, a division of government that would be a division of the ministry that would focus on long-term care policy issues. And so I joined the ministry last October, just after Thanksgiving, and started the work of building up a division that can focus on some of the critical policy issues in long-term care. The slide covers some of the areas of my responsibility in my division. There are a range of policy issues that are really important in modernizing the sector. The minister touched on staffing as a really key issue, and one that we've been spending a lot of time and energy on. We have an advisory group that she referenced that we're working with, and preparing a staffing study to try to chart a path forward to have to better support staff, to better support resident quality of life. We're also looking at innovations in quality of care and ways we might, as the province, support long-term care homes in innovative approaches that can better support residents. I also have responsibility for the operating funding for long-term care, and so looking at the funding policies. And as well, there's a lot of change going on in the broader healthcare system. And one of the things that we can do, given the focus that we have now on long-term care, is try to better integrate long-term care within a broader transformed healthcare system, or a broader continuum of care, as we sometimes reference. Another part of my organization has been leading the coordination of government's response to the public inquiry into the safety and security of residents in the long-term care homes. And that inquiry report that was led by Justice Elliot reported last July 31st with many recommendations directed to government, to the LHINs, to long-term care homes, to others. And so my team has been coordinating the follow-up on those recommendations, and we anticipate there will be a progress report made publicly available by the anniversary of that report in July. And then finally, as part of the funding responsibility, I have a team that is responsible for overseeing and ensuring accountability for some of the specific programs that are funded through the ministry. So whether that's programs like Behavioral Supports Ontario, or the Falls Prevention Program, or specific initiatives that are designed to try to improve or address specific issues in long-term care. So that's a brief overview. Maybe just in closing, I'll say that as a result of our experiences of the last few months, we are refocusing in some ways our energies and efforts, and maybe perhaps looking a little bit more broadly at issues around modernization. As the Minister referenced, we'll be supporting government in setting up an independent commission, and I'm sure that our agenda will continue to evolve as the government reflects and learns from our collective experience over the last number of months. So I will stop there and let my colleague Brian introduce himself.
Thanks, Janet, and good afternoon, everyone. I'm Brian Pollard. I'm the Assistant Deputy Minister for Long-Term Care Operations within the Ministry of Long-Term Care. Before I talk about what I do today, let me probably just spend a couple of seconds talking about what I did before taking on this portfolio. So I have been involved with long-term care for probably the last decade or so. And before that, I was in the hospital sector for a period of time. And before that, I did something completely different in engineering. So I have quite a bit of varied experience. But, I think it's worthwhile to kind of point that out to you, because what you get with Janet and myself are a good set of complementary and diverse opinions, which I think makes the division a lot stronger. So as Janet said, we became a ministry last about a year ago. And before that, we were a division in the Ministry of Health and Long-Term Care. And I was the Assistant Deputy Minister for the Long-Term Care portfolio within the Ministry of Health and Long-Term Care. So when we formed the standalone Ministry of Long-Term Care, I came over as initially as the ADM for Long-Term Care, and then Janet joined me in October, and she became ADM for Policy, and I became ADM for Operations. And under the ADM for Operations portfolio, there are really three big buckets of work that I'm responsible for. The first one is inspections, and you'll see there that requires me to be responsible for the delivery of the LQIP, or the Long-Term Care Quality Inspection Program. And hopefully some of you were able to join our webinar last week when we talked about that program in more detail. The second area that I'm responsible for is licensing and capital development. And of course, with the government's commitment to build more beds and redevelop more beds in the province, we are very busy getting on with that piece of work. Probably even more urgent now, given some of the challenges we've seen with some of our older build homes in the province in the wake of COVID. So that will be another kind of exciting task for me to continue working on. And then finally, all of you are probably familiar with the Long-Term Care Act and its regulation, which is really very much based on making sure that you have the appropriate underpinning for operational oversight, and responsible for leading the strategic and legislative and regulatory developments that would be related to the Long-Term Care Home Act and regulation. So that's my portfolio. Before I turn it back over to Dee, let me acknowledge both Dee and Sharon. I think it's worthwhile for all of you on the webinar to know that these are tireless leaders who are not shy to let government know about your wishes and how we can improve the system, and we thank them very much for their collaboration. So Dee, back over to you.
Thank you, Brian. Thank you very much. We have, as you can well imagine, many, many questions, and certainly with starting a little bit late, some anxieties around time management are starting to bubble up. So I'm wondering, Janet and Brian, could I ask, would you be available to stay with us for a few more minutes after 4 o'clock? Is that okay? And we can gauge our time accordingly?
I have to check my schedule, to be honest.
Yeah.
Okay. Well, let's get into this. Okay. On behalf of David Kent, Vice President of OARC, David is a resident living at the village of Erin Meadows in Mississauga. David would like to know what special techniques do the homes use in order to, in older homes when they have 4 beds in the room. So infection control and prevention is impossible in those homes. How do they deal with COVID?
Yeah, it's a good question, David, and I think it really depends on the design of the home. So some homes would have been able to deploy people to vacant spaces. Some would have cohorted, if unfortunately homes did have COVID, they would have cohorted COVID positive residents together and COVID negative residents together. Yeah, if it was a multi-floor building, people would have been cohorted on different floors. So it really does depend on the design of the home. What I would say is that certainly through the efforts of Public Health Ontario, local public health units across the province, indeed even some of our inspectors and others, many homes who were there's either an assessment that was done to help them with some of those techniques, and we actually engaged hospitals in a lot of that work as well, and some of the techniques that they could deploy, or certainly in not only kind of giving advice, but going on site to help them with actually implementing those techniques. So it could be any number of steps and approaches that homes would have taken, David.
Thank you, Brian. Thank you. Another question comes to us from Reed Walker. Reed is secretary for OARC, and he lives at Chartwell Branch Center in Burlington. Reed, are you on the line, or shall I read the question? I think I will go ahead, Reed. I apologize for not being able to get you quickly online. His question is this: our frontline workforce is unstable. I believe that compensation must reflect the value that our frontline workers bring to our lives. Is there a plan being developed to address this? Related to compensation for frontline team members.
So I think that was for me. Are you hearing me okay?
Yes, thank you.
Thanks for the question. Certainly went through the staffing study that we've had underway. Compensation is absolutely one of the questions we have, the issues we've heard about, along with issues like access to full-time employment, working conditions, whether there are enough staff to enable staff to take the time to do their jobs well, or whether they feel rushed through and not able to take time to engage in the care tasks care activities they think are necessary or being asked for. So absolutely compensation is on the table. It's a complicated question, and I can't provide you with a definitive answer about what government will choose to do. I think there are a number of things that people are talking about with respect to staffing that would require additional investment, increasing compensation for staff, increasing the numbers of staff, increasing the variety of types of staff who are available to support residents. And when we complete the staffing study, then there'll be an opportunity for the government to consider some decisions about next steps. As public servants, Brian and I give our best advice, engage in these kinds of conversations, and bring back what we're hearing. But those kinds of budgetary decisions rest with the politicians. And Dee, I will also just say I can maximum 4:10. I have another call set up.
Okay, thank you, Dan. Thank you. Okay, so we are going to flip over to Josie Lee and Melissa very shortly to interject some of the questions coming in by the chat box. But while they get their questions organized, I'll ask this one. In the documents from government with regards to visiting, there are two terms being used. One term is essential visitor, and the other term is essential family caregiver. What is the substantive difference between these two classifications of visitors?
Yeah, so I can talk to that, Dee. So once the ministry determined that it was appropriate to start thinking through how we were going to restart visits into long-term care, we certainly did reach out and consult with both the Ontario Association of Resident Councils, yourself, and Family Councils Ontario. And one of the terms that we heard repeatedly needed to be highlighted and brought to the forefront was the notion of a caregiver, and to be more specific, an essential family caregiver. So we pulled out that terminology and highlighted it and put a very specific definition around it to be clear that these people were going to actually be supporting loved ones in long-term care with kind of the essential elements of family caregiving. And that would really probably be on an ongoing basis. The essential visitor category, so the essential family caregiver is something that we've introduced obviously with the release of the visit guidelines and guidance. The essential visitor concept is something that we've had in the guidance from pretty early on. And that really was put in there to reflect that there were going to be some element of people who would still need access to long-term care who would not have been routine staff members. So whether it was, a phlebotomist or a pharmacy or any of those kind of support services. And, so the intention of the essential visitor one was to make sure that, one, they were not forgotten as a key element in caregiving, and secondly, that it was clearly articulated what the screening guidelines and other expectations would be for those people. So, and for those professionals. So I would say that is the main distinction between the two. I know that there have been some questions, and maybe this is what the question is hinting at. There have been some questions about whether there's an overlap between the essential visitor and the essential family caregiver. I hope the guidance makes that a bit clearer, that we don't have to guess anymore about whether an essential family caregiver is an essential visitor. And, that was really the intent of clarifying that, and I believe that was the one of the reasons why associations or our advocacy groups wanted us to certainly isolate and identify the family caregiver element. Have I lost B?
I'm sorry, Josie Lee, I'll be right with you. The last question on my end for the immediate time here. Again, visiting starts today. The visitor policy released by government states that visitors must attest to having a negative test prior to coming into the home within the last 14 days. However, Directive number 3 states that visitors should attest to not be experiencing any of the symptoms. So I'm wondering if you could clarify for us, please, do visitors need to attest that they have no symptoms and or attest to having a negative COVID-19 test?
Yeah, I can answer that. So it's an and D. So to your question, the whole part about attestation to symptoms is really something that's been part of our active screening for many months now. So what we're adding on to that is that you would also be attesting to having been tested in the last couple of weeks. So to your question, it is an and.
Thank you, Brian. Thank you. Okay, Josie Lee, over to you for some questions from our chat.
Thank you, Dee. Good afternoon, Brian and Bennett. We do have a question here in the chat around should we see a second wave of this virus, how are you as a ministry preparing for that?
Do you want me to start, Janet?
You could start and then I'm happy to join in.
Okay, so yeah, I mean, hopefully, and I'm knocking kind of proverbial wood here that we don't have a second wave, but obviously it's prudent for government to be thinking ahead to that being a real possibility. So what I would say is that we have learned quite a bit coming out of the last 3 months in terms of how to better support homes in getting ready for a future outbreak. I mean, if you take something like we were just talking about, like PPE, personal protective equipment, I think we've now all probably learned that we need to have a bit more than a couple of days of stock of PPE should something happen. So we would certainly be expecting and looking for homes to have more PPE available, as an example. Another area where we know it has been challenging, and it goes to David's question from earlier, is IPAC, so infection prevention and control. So certainly making sure that all homes take this hopefully better time that we're in now to make sure that all staff are trained on IPAC, that an assessment of the home has been done on IPAC, and that it becomes really integrated into the fabric of how the home operates, so that those protections are in place. And then maybe the final observation I would make, because I think it's a little bit easier than obviously, some of the design issues that we're faced with. The final observation I would make is that certainly we now have an opportunity to rethink our medical and clinical model in terms of coverage. One of the observations that we've had throughout the COVID experience, that probably wasn't as robust a support model as it could be. So there's certainly an opportunity to look at how we quickly retool and strengthen that in the short term. So I could go on, but those are just kind of three quick examples. Janet, I don't know if you want to add anything.
Sure, thanks, Brian. So absolutely, I think we're all doing a lot of reflecting. I think in the first number of weeks and very intense weeks of the pandemic, it was hard to be frank, to have any time to reflect. We were all running pretty fast to try to understand what was happening and what we needed to do to try to support homes. So there's a lot of reflecting going on now, both on our part within government, but also I think in conversations with associations and understanding whether it's associations representing residents, families, or the homes themselves. I think one of the things that we are trying to make sure we have better lined up in the early days of our experience with the pandemic, we saw in some homes that experienced outbreak significant decrease in staffing levels, whether people were themselves as staff becoming ill or needed to self-isolate for a variety of reasons, had family members with underlying health conditions that made them concerned, or whether we had some staff simply, afraid of what was happening. And so we have built up mechanisms that helped us to redeploy people who were not actively employed but had some skills that could be helpful in a long-term care home. So we've now sort of got those mechanisms operating, and we're looking at how we can keep them in place so that if we, God forbid, found ourselves in a second wave, we would have those tools at our fingertips more quickly than we did the first time around, where we were building things while we were experiencing the pandemic. So that's an example associated with staffing redeployment. I think another thing I will point out is we have recently, as a result of Directive 3 being released, started to permit admissions into long-term care homes from hospitals. And part of Directive 3 says that we will not do so into 3- and 4-bedrooms. So with respect to new admissions, we're limiting for the time being to no more than 2 people in a room. And that's really, I think, a measure at the moment to be cautious and to make sure we're not, if we know that those 3- and 4-bedrooms tended to experience challenge when there was outbreak, we're trying not to get ourselves into that situation of great challenge in the immediate term. So those are a couple of more items I can offer.
Thank you, Janet. Thank you, Brian. Josie Lee, do you have another question?
Hi there, Dee. It's Melissa. And actually, this is a perfect segue after hearing from Janet. There are a number of questions in the chat about long-term care home redevelopment. So the question is, will design standards for new homes be changed to reflect the lessons learned from COVID-19?
So I can take that one. So I think it would be probably fair to say, coming out of COVID-19, that we need to probably have a quick glance at our design standards to see if there's anything that we would want to change pertinent to COVID-19. One of the observations that we have in government is that our newer build homes, so those that are built to the newer design standards, and we have even newer design standards than the ones that are currently in the field. Those homes did quite well in terms of coping with COVID-19. So we now have 2015 design standards. Any home that's redeveloped or being built will have to build to those design standards. Those are newer than the 2009 or even the 1999 design standards, which were some of our newer homes in the system. And those homes, as I just said, are the ones that did that's fair to say. So we will have to look at it. I am not, but I can't guarantee this is true. I'm not expecting that there will be any need to significantly change our design standards. As you know, those design standards call for 60% private at this point in time, and 40% basic, so majority private rooms. Many people have kind of said to me, well, maybe we need to look at stuff like HVAC or whether we have a different sort of bathroom design. But I think that is more speculative now than necessarily supported by evidence. So long answer to a short question, yes, we'll have a quick glance at the design standards. Doesn't necessarily mean that anything will be changed.
Thank you, Brian. We do have a number of questions in the chat box around the staffing, but the one I wanted to put forward is from a resident in Paris, Ontario, who was wondering what are the plans to address staffing levels to provide quality care. Currently, there are 2 staff, 24 residents. Staff are burning out. Residents need to increase. How are we going to get residents the care that they need and deserve?
Josie Lee, you're cutting out, unfortunately. We can't hear you.
I think the question in its essence was around what is government's plan to increase staffing ratios, and the example was given 24 residents to 2 team members. Team members are burning out, feeling discouraged, etc., and quality of care is going down, and this is from a resident's perspective.
So thank you for that question. And thanks for repeating that. I had a little difficulty hearing. So this is certainly very much in line with what we're hearing in the staffing study that has been underway over the last number of months. We did have to pause the study for a couple of months, but pardon me, that we have been undertaking with an advisory group, as the minister mentioned. And I think one of the things we have heard a lot about is an overall concern about whether there are enough staff to provide the care and assistance that residents require. We've heard a lot about burnout. We've heard a lot about how physically demanding the work can be, how staff may feel that they can't take the time they need to respond to what residents' needs are. So your question is very much in line with what we're hearing across the province. Similar to my response on the question about compensation for staff, what we'll be doing in the staffing study is laying out what we're hearing about a range of options that could be considered to help ameliorate the situation. And we'll work with our political leaders to get their decisions on how they'd like to proceed, and then we'd like to work with the sector around implementing the directions that are chosen. But I can't at this point in time tell you exactly what those will be because those decisions haven't been made. I would maybe just add that our experiences over the last number of weeks with the COVID pandemic have, I think, shone even more brightly a spotlight on some of the staffing challenges. And I think there's a high level of awareness amongst the politicians, the 2 ministers that you heard from earlier today, but they're also their colleagues, a high level of understanding that this is an area that requires some attention. Thank you.
Thank you, Janet. My next question has to do with the care that residents can expect during crises like this and other outbreaks, quite frankly. We've heard from residents that baths have stopped in their homes due to COVID-19 precautions. They're going weeks on end without baths. Can you speak to what residents can expect regarding this necessary health provision? And that question is from a resident.
Yeah, so I can certainly speak to it. You know, the requirement on homes continues to be that you provide a safe, secure, high quality care environment in homes. I think we probably all appreciate that in a time of COVID pandemic, they may not necessarily be able to operate to the same level as they were doing before COVID. But you know, that is not meant to be a permanent approach by any means. So I would say our expectation continues to be that homes are complying with all of the expectations of the Act and the regulation and any emergency orders, etc. So you know, and if that is not happening, a complaint can certainly be lodged in our complaint line or to our complaint line.
Okay, thank you, Brian. And similar to that, what can residents expect regarding quality of food and food choices during these challenging times? Again, we've heard that a number of residents are experiencing meals that are cold, no choice provided, very little to no assistance provided, etc. So can you comment on expectation for quality of food?
Yeah, our expectation is that you have high quality, nutritious food that is in alignment with your care plan. So again, if that is not happening, we would like to hear about it. But there has been no direction given, best I know, that people should be getting anything but high quality food.
Okay, thank you. I'll ask one more and then I'll pass it back over to Melissa. The new visiting program, and this comes from a resident, starts today. My home is scheduling visits Monday to Friday during the day and not over the lunch period. It's making it difficult to schedule an appointment with my family who works full time. What can I do about it?
Yeah, just repeat it. No, we didn't put any stipulations in terms of the visiting hours. So were the visiting hours only, did you say 9 to 5?
Yes, and this is a repeated question that we are getting, Brian. Some homes, we have learned that some homes are creating visiting schedules that are 9 to 5 or even 10 to 3. Not in the evenings and not on the weekends. So I'm wondering if you can give some guidance around that.
Yeah, so my guidance on that would be to certainly flag that as an issue with your administrator and local home staff. Certainly from the ministry perspective, we've been very clear that visits need to be meaningful, and they need to be at least a half an hour in length, and that certainly homes can schedule them. But we did not indicate that scheduling can only take place between 10 to 3 or 9 to 5. So I think if from a consumer perspective, you need to have different visiting hours become available, you should absolutely flag that with your home, and start there. And obviously, if it persists, just let us know.
Thank you, Brian. Melissa, Josie Lee, do you have a question?
Sure, there is one that's come through that's also on the topic of visitation. Family members who live in seniors' residences will find it difficult or next to impossible to meet the requirement for a negative COVID test because many residences require persons to isolate for 14 days should they choose to leave the building, for example, to leave for that COVID test. Any thoughts on putting in place a process for these persons to be tested in their residence?
So they would be living, I just want to make sure I understand the question, Josie Lee, they may be living in next door neighbor in long-term care home. Is that kind of the concept?
Sorry, Brian, you cut out there, but I believe so. Yes, the seniors' residences, like that, maybe a spouse lives in a seniors' residence and they'd like to visit their loved one in long-term care.
Campus or care, yeah. So I'm assuming that in most of these situations, it is a campus or care construct that we are working with, and probably the same licensee. So again, I would kind of probably use the same approach that I just talked about. Have a conversation with the local leadership in the home and see if there is an approach that can be determined. If it is becoming, if there's something prohibitive in the directive that we need to look at, even after person speaks to leadership, somebody can funnel that through to the Chief Medical Officer of Health, and we will look at that. So it can come through our complaints line if necessary.
Thank you, Brian.
Thank you. Janet, I do know that, and Brian, our time has quickly come to an end. Just before we say our goodbyes and next steps, Brian, I'm wondering if you could talk very quickly about the type of inspection called an inquiry. Can you explain what it is and when they're used, how it's determined when an issue is inspected, versus or via this method, so an inquiry inspection?
Yeah, so we talked a bit about this on our call last week, but happy to kind of give a very high-level response just in the interest of time. And I believe I heard you say, Dee, that the session from last week was recorded and is available in the archive somewhere. So in general, an inquiry will be used for a lower risk inspection. So these are not cases where there has been significant risk of harm or harm to residents, instances of abuse or neglect. In those cases, we would have, those would be considered high risk. So an inquiry will be used in a low risk situation. It can usually entail documentation being sent to the ministry, phone interviews occurring, etc. And those, those inspections, those inquiries will also have elements where the inspector would be liaising with family members to let them know the resolution and the outcome of the inquiry. But I think an easy way to think about it is that that type of inspection is used for lower risk instances.
Thank you, Brian. If any, we do need to wrap up, and I'm respectful of the gracious time that you have given us, both Janet and Brian. If any of you know anything about me, you know that I'm all about collaboration. No one person or organization holds that magical golden key to solve the problems in long-term care. We all have a vested interest in the success and viability of long-term care. Brian, OARC has been a partner of yours for years. I know you, and I know your commitment to residents' quality of life. Janet, although OARC is new to you, I'm encouraged by your desire to meet with and develop relationships with OARC early on. Thank you very much for your attention today, for your comprehensive answers. It really means a lot that we have this opportunity with you. Thank you, Brian. Thank you, Janet. We will say goodbye to you for now. We look forward to next steps with you. Perhaps we can have a similar webinar a little bit further down the road. Thanks again, everyone, for joining us now. We will have, soon after you sign off, within moments, you will receive an evaluation questionnaire. Please take a couple of moments to fill that out. It will help us move forward in better ways to serve you. And just before I say goodbye, we talked a little bit about communication today between homes and residents.
Oh, I think we've lost Dee's audio.
Thank you from us, though, to OARC.
Thank you both, Janet and Brian,
Thank you so much.
Our participants today.
Okay, bye-bye.
Thank you.
Good afternoon,
Thanks, it was a
everyone.
pleasure. Bye-bye.
Bye, thank you.